Good afternoon, everyone. I would like to welcome all of you in the King Khalid Retinopaxis Grand Round lecture for today. Our distinguished speaker is Dr. Adel AlAkeely, Associate Director of Outreach and Eligibility, Consultant of Retinal Divisions in King Khalid, Eye Specialist Hospital, and he's the ophthalmology champion in the Ministry of Health. His title is interesting, and he's gonna to talk about the reviving the dying art of scleral buckling. Welcome, Dr. Adil, and would like to start your talk if you don't mind.
Thank you very much, Dr. Hassan. I really appreciate the nice introduction. And I would like to take you all in a journey in memory lane. So in the beginning, I'm gonna show you a case, and I want you to think about how you would deal with this case, and then we'll start our talk. So this is a 25 years old lady who has a vision of 20/20 in both eyes that recently had refractive surgery, and she noticed that she developed a change in her vision in the right eye. So she comes to us with this clinical picture, and if you can see, there is this inferior retina detachment with PVR. And when you look into the OCT, you find that the detachment actually has reached the level of the fovea, at the edge of the foveola actually. And her vision is still 20/20. You look at the other eye, and you discover that she has this detachment. She is fortunate that this detachment is only reaching the edge of the macula, and the macula is not involved. But it's not a very pretty detachment. A lot of breaks, PVR as well, and she didn't even notice the change in this eye. So what do we do? Always when we think about doing retina surgery, maybe ourselves don't think of that much, but our colleagues in other specialties think about the complication that we might have: glaucoma, cataract. Complications related to the surgery, such as subretinal perfluorocarbon, eventually band keratopathy, and even endophthalmitis. This is when we go into talking into vitrectomy. But when Jules Gonin started to describe the procedure almost 100 years ago, the scleral buckling, he had an epiphany where he started this trend, which is still alive until now, which is the scleral buckling. There were a lot of ways of treating retinal detachment at the time, and most of them were failures, and they actually ended up with a lot of complications that are, very weird for us right now. When he discovered the idea of the causative break and its role in the pathogenesis of RD, his principle was to target this break and treat it, and then eventually the retina will flatten. He tried for a very long time so he started around 1920, and he waited till his work was published in the 1930s, and his disciples started to have similar success and popularize the procedure, which we know now, the treatment of retinal detachment. So again, there are certain ideas that the scleral buckle work around. So we need to have good visualization, and the visualization starts from the presence of the indirect ophthalmoscopy. But the indirect ophthalmoscopy was also something that was discovered late in the 19th century, and it was popularized with time by a lot of retina surgeons such as Amsler, and they started even to draw the picture that we know now of the retina in terms of what are the breaks, the extent of the detachment, and the changes that we describe in our retinal exam. But it was Charles Stephens who actually started the head-mounted indirect ophthalmoscopy that we have now, and we use, although with decreasing frequency in our clinic, but it's still valid as and a very important tool. And this was discovered, or first started to be described in the 1940s. He also described scleral depression with that procedure as well. And in terms of retinopexy, which is the idea of attaching the retina, this was also discussed by many, and it was not until Harvey Linkoff who created the first cryoprobe where we started to use the same technique in our procedures, and this was discovered or started in the 1960s. Scleral buckling as a concept was there for some time, but it was used in the idea of shortening the globe in order to return the retina to its position. However, this was done in very, very different ways in terms of scleral resection, and this was a very different idea at the time. But using the scleral buckle as we use it right now as support to the brake was initiated later on in the 1930s. And what we have now in terms of the technique of using silicone rubber implants and sponges and needles were all developed by pioneers such as Charles Stephens and Harvey Linkoff. So what are the techniques of scleral buckling? Scleral buckling is a procedure that's basically a process rather than a surgery, only a surgery. So you start the surgery or the process by a very careful pre-op assessment. And this includes talking about the macular involvement, features of the retinal detachment, the presence of PVD, and other comorbidities, number of and positions, and the level of the retinal breaks, and the lens status. And we always remember this golden rule of Linkoff, which he described in terms of the presence of the break and the extent of the detachment. In terms of the surgery itself, it's very important to remember that doing a very good periotomy and very well dissecting the Tenon's capsule is very important in our surgery. This is how we do it. We snip the first time to open the conjunctiva, and then we snip the second time to open the tenon. And we also remember that as slinging the muscle is also has to be as in a certain way. You want to go to the superior rectus coming temporally and to the lateral rectus coming superiorly in order to avoid the slinging of the obliques. Getting a very careful look at the sclera after you remove the conjunctiva is very important. You don't want to operate on a patient who has scleromalacia. And in terms of the visualization, we talked earlier about indirect ophthalmoscopy. However, there are very new techniques that we are adopting these days in terms of using the chandelier endo-illumination light and the visualization systems such as Biome or Resights. And you need to know that the visualization is the most important part of the surgery. So it's always advised to keep this in mind in terms of operating, because if you don't see in a scleral buckle and in any surgery actually, you basically are looking for trouble. Remembering how we do the examination is very important. So you want to depress on the brake, and you always want to remember the parallax phenomena where you actually can depress and the difference in level of the high retinal detachment and the sclera can sometimes produce differences. So you can see that the brake here is at this level, but when you depress and at the level that you see during your exam, you basically are depressing more posterior. And this can come with its own problems. Retinopaxis, as it evolved, is now a very nice and simple procedure. You look at how we're doing the cryopixing these days, look directly compressing the break and then applying the laser. In this case, it was the single break where we actually could treat it with just one treatment, and you can see how the dark retina appears and confirms the presence of the break. Sometimes you have those large breaks that you can't actually treat with one application of cryo. I'm sorry, I'm talking about cryo here. So you might need to apply it in different location but you need to keep in mind that you don't want to treat the same area twice because of the risk of the cryotherapy. And there is this very known and very worrisome chance of you missing the exact time location of your depression with the cryo, where you actually might compress with the shaft of the cryo and then laser somewhere even posteriorly, which might cause very posterior laser treatment. There are other modalities for retinopaxis. We know that we utilize a lot, and laser and direct ophthalmoscopy in the OR. There has been also talk about diode in treating retinal breaks. However, this is something that has not been adopted a lot. And you can also see that we still have the chance of treating with laser even after the procedure in an outpatient setup. I'd also talking about
an additional posterior hole was identified under the inferior rectus muscle that the bulkier cryoprobe had difficulty accessing. Decision was made to proceed with marking of the break and placement of the buckle with external fluid drainage. Here we see the break now supported on the buckle. A continuous moderate power laser is then applied using an endolaser probe for retinopaxy. After an anterior chamber paracentesis, the trocar is removed and the sclerotomy is sutured. Keys in our small experience using laser probes in non-vitrectomized eyes is minimizing insertion of the probe and using a larger spot size and continuous moderate power laser. This is a potential useful adjunct in situations where extensive therapy is required, such as lattice degeneration, and access to indirect laser is more limited.
Talking about scleral explants, there has been a lot of development in this field in the past, but now we reach the consensus that the use of silicone is a very inert material and has been very well tolerated for a very long time. These are all examples of what we have in terms of silicone exoplants. As we can see here, these are the tires in their different sizes, and also you can see their different segments, and then the sponges and the sleeves and the bands that we tend to use a lot in our patients. It's important to know that this does not come with its own complications. There has been reports of sponge abscesses, and this is why we don't have the air cells opened in these. These are all closed cell air sponges or closed air cells sponges. And these are the effects that we see with the sponges. We typically think of them as a way to treat locally some our breaks, and this happens as we target them very carefully. Whereas in the cases of tires, we tend to use them as part of our broad adhesions. Or broad support to the retina. So they typically have lower height but broader reach. In terms of suturing, we use durable materials which are biocompatible because these are non-absorbing sutures. We want them to be easy to handle because we know we are going into very small spaces going back in the sclera to reach our anchoring sutures. So monofilament nylon has been used very frequently. However, there are some braided polyester which are more easy to handle and has gained traction a lot recently. It's important to know that these Nylons are very helpful in terms of having the memory to stick, and the friction that we have between the two threads will help us not need any support during suturing those bands. Always remember that suturing is always an art, especially in those buccal cases, because you want to be parallel in orientation, and you have to have the long axis of the explant in between those sutures. So you want to have radial suture bites for radial explants and circumferential for circumferential implants. And remembering the size of your element and the distance between your bites is very important in order to create the desired depression. So this is one of the cases that we're using a radial buccal, and if you can see here how we're it's very difficult to reach this position. It might have been easier to come the other way around, and then at the end, removing the suture, you want to be careful not to injure the sclera with the heel of your needle. Now looking at how we are actually introducing our sponge in this case, and how we want to suture it in a way that supports the position we want. There are also some advances in the technique. So now we have been using more frequently the scleral tunnels, which are very useful in especially the non-high myopic patients. It can be somewhat less time-consuming than the suturing, and especially if you're using those kind of curved crescent knives, it can also accommodate very nicely your 240 bands. And at the end, you might not even need to suture those when you reach the Watson sleeve. Subretinal fluid drainage is one of the debatable issues when we talk about scleral buckling. And in a randomized controlled trial, there was no difference actually or advantage for subretinal fluid drainage. However, we want to know which are the cases that are selected or preferred to be treated with subretinal fluid drainage, because depending on the height and the configuration of the detachment, you might want to do drainage in some cases. And so it's always helpful to familiarize yourself with the technique, even if you don't frequently use it. So there are different techniques of drainage. The general concept was, in terms of the timing, you want to drain and use air if this is one of your techniques, and then do cryo and then put the explant. This will help you know where exactly is the break after you drain, and then when you do your cryo, you're sure that you're treating the exact location of the break in relation to the sclera. You want to avoid the ciliary nerves and the vortex veins, because you don't want to fall into this very scary complication of developing a subretinal hemorrhage during this step. This can happen especially in those fresh detachment where the subretinal fluid is not very thick, because the blood will typically gravitate to the macula, because it's the most dependent point in the back of the eye. And you want to also remember that there are other techniques of different techniques of doing this. So you can do the cut down technique where you dissect through the sclera fibers until you reach the choroid, and then you open the choroid, or you can use the needle technique, where you actually can control exactly how much you're going in by measuring the distance between the edge of the needle and your needle holder. And there are other techniques such as cryotherapy, diathermy, or direct aspiration. This was a very nice technique that was described by our friend and colleague, Dr. Adel AlAkeely, and actually he was nominated. He won one of the Euroretin's video presentations about it. where he actually is introducing carefully under direct visualization the 26 gauge needle with a cannula, and then by controlling the injection of the fluid, he expresses the subretinal fluid and doing it in a very controlled way. And you can see how totally the subretinal fluid here. There's another technique or another instrument that can be used in this kind of situation. Maybe this is not the typical the picture you want to see with the scleral buckle. However, this was a case of a TRD that had subretinal fluid and no breaks, and it was very bullous. So this was very useful. You can see the rubber ball there is protecting you from injuring the sclera or penetrating the sclera until you reach the exact area. And as we inject the perfluorine here, we're expressing the fluid into this device that was connected to a syringe. And this is how you might be able to drain in a controlled manner. So, talking again about scleral buckling, we mentioned earlier that that complication that might develop with vitrectomy. However, complications that from or scleral buckle by itself is not immune from complications. And these are just some examples. We have fish mouthing of the break here, and this is due to those radial folds that developed from a tight buckle, and a missed break here that was not treated, and a break that was not actually a buckle that was not high enough to support the break. There's so many different techniques of doing scleral buckle, and this is the reason why you should pick and choose what's best for you, because I think scleral buckle is here to stay again. This is one technique that was described by our colleague, Dr. Juan Martinez Yepes, where he does periotomy sparing scleral buckling. This is how I learned that from him. You basically do your traction, bridal sutures as you do in the ACCE, and then you start creating your limited conjunctival openings at the edge of the between the muscles, and then here we're using the Scleral Tunnel technique to go through the whole 4 quadrants and passing underneath the muscle without even opening the conjunctiva there can also be done, and then ending up by putting the sleeve, and the patient was happy from the cosmetic results in the first immediate post-operative period. Again, you want to use whatever suits you to get the job done. So you might even need to use radial buckles, and then discover that there are other breaks, and then use another radial buckle. And in this case, we use 2 radial buckles for a patient who had 2 breaks in different levels, and did not need to place an encircling band in this case. Sponges can be used in any way you want. It's not just radially. You can use them even in a somewhat circumferential situation. This is a patient who had a chronic RD with those massive cysts, and then we reverted to using the sponges in a circumferential, semi-circumferential way, where we actually treated less than 180 or supported only less than 180 degree of the retinal of the retina inferiorly. Again, the concept with the sponge is that you want to tighten it as much as you can in order to displace it into the and push the sclera into posteriorly, and this will, although at the first post-operative or immediately you won't feel that indentation, it might even increase later on. So going back to the case I discussed earlier, This patient that we mentioned that had that was 25 years old and had those detachment macula involved in the right eye and the macula in the left eye. We had to discuss with her the options of operating. We know that sometimes the subretinal fluid can progress in a slow manner. However, she was very keen to get treated for the situation, and this is a very important added value that you get with scleral buckle. We ended up operating in this patient in both eyes, where we placed an encircling band in the right eye, and in the left eye we placed an encircling band and then added an element of a radial sponge that supported the posterior inferior brake, and she ended up being flat and did not need to have any vitrectomy. So again, when we think about scleral buckle, the general concept here is that we want to remember where we came from. We came from a disease that was tackled by extraocularly, and although this was a very difficult procedure in the beginning, there was good success rate in the beginning of almost 100 years ago. So now that we are developing new technologies and new techniques and different visualization systems and our abilities to understand the anatomy and the pathology of the disease has increased, I think that looking at what we had in our hand and evolving it has a very important value. Knowing that this is a very useful tool makes us work with it as much as we can. However, we want to remember that this procedure, and it's understandably less popular these days because of the risk that it bears. And this is one article that was mentioned, that they mentioned the effects of the duties that we do as ophthalmologists on our health. And if you think about this discussion about a cataract surgeon who performs a surgery in less than 30 minutes and only sees the patient with a slit lamp, compared to a surgeon that will stay, a retina surgeon that will do a scleral buckle in a conventional way, where he will use the indirect for all the procedure for a very long time. You can imagine how worse will his back be. And understandably, this is why many of our retina surgeons colleagues have lost the interest in the procedure. But this does not mean that this is the end of the way. I think that it's always important to remember that if you think that this procedure is the right procedure for the patient, you have to do what's right. And in that case, in my belief that I presented to you earlier, I think that the right decision was to do a scleral buckle. So when you think about it in this way, you want to work on developing the methods to make this procedure tolerable for the surgeon and the patient as well. And this will only happen with evolution and trying new techniques and adopting new technologies. So this is what took us to what we did in this case, in this study that I'll present to you, that was published recently in the American Journal of Case Reports. This was a study that we shared our technique in chandelier-assisted scleral buckle using heads-up display system. So basically, the chandelier endoillumination has been used for buckle for some time. It had the added value of showing real-time what's happening to whoever is in the room, whether it's a trainee or your consultant if you're a trainee as well. So it has been proven to be a very good educational tool, and there has been a lot of publication about it. And it was one of the reasons why a lot have came back to using scleral buckle after they stopped doing so. What we described here also in that technique is in this paper was using scleral tunnel. Dr. Hassan, do you hear me? I think I'm. Dr. Hassan, do you hear me?
We hear you.
Okay, excellent. Because I had the message that I was signed out. Okay, so Scleral Tunnel was associated with these complications compared to scleral suturing. This was in terms of the number of inadvertent penetration. We know that Scleral Tunnel can cause perforation as well, but also buccal infections and extrusions have been shown to be less. It also avoid the unnecessary and irregular buckle that occurs sometimes with suturing, because it's usually an even plane that you work on, and it also helps us prevent the unnecessary or not necessary to tighten the band more than the required that we have sometimes in cases of scleral buckle in a routine way. A 3D visualization system, which was also used in this technique, has also proven to be a better, provides a better image quality, field of view, focus of depth, illumination, and ergonomics. And also has been shown to reduce the light toxicity, because you can reduce the amount of light that you introduce into the eye using the same setting. So in this study, we reported the anatomical and functional outcomes of chandelier-assisted scleral buckle with sutureless scleral tunnel using a 3D visualization system in primary phakic rhegmatogenous retinal detachment. We included patients in King Khalid Eye Specialist Hospital from March 2019 to February 2020. And all the patients we did underwent general anesthesia with encircling band and standard cryo to the therapy to the break with no additional elements. And this is the demographics of the patients. You see that most of them were to the younger side, and most of them had inferior detachment with multiple breaks in one of the patients. And one of them had retinoschisis. The best corrected visual acuity was actually good to begin with in most of those patients. And this is how we do our procedure. We start by slinging, opening the conjunctiva, periotomy, slinging the muscles, and then creating our, isolating the break or localizing the break, and then treating it with cryotherapy. And then creating our cut down, partial thickness cut down of the sclera, which I use the crescent blade available from Alcon, and I have no financial disclosure here or financial associations. We pass the band underneath the muscle, and it's important to know, and I tend to do this a lot, is you want to. One reason that many don't like to do buckles is that you feel that you need the help of others during the procedure. So adopting a way that you hold the muscle, the tractional sutures, and then passing the band by yourself and receiving it from the other side will be very helpful in terms of you doing more procedures, because you don't always have a good assistant with you in the surgery. And in this case, we actually sutured with the absorbable suture of the conjunctiva. However, you can do this with the cautery without the need of any sutures. So in terms of the results, we were successful in reattaching the retina in 5 of those 6 cases, and the visual outcome was good. One of them who did not achieve the primary success with a buckle needed another vitrectomy, and was successful. So the overall success rate in our small series was 100%. the reason for that failure of the primary buckle was there was a missed break in that case, and so which was normal when you talk about sclera buckle. It's a very well-known reason for failure. So back to the point that I was mentioning earlier about how sclera buckle is an important tool that's still adopted in our practice. This is the results of the second report for the primary retinal detachment outcome study, where they actually compared vitrectomy or sclera buckle combined with vitrectomy. Sclera buckle alone with vitrectomy alone or combined with the SB, and they noticed that the success rate was actually in the late 80s. It was in the 92% in this study group, which was higher than that one that was achieved with the vitrectomy group. Although it's always important to know that these studies that compare different procedures, such as those, as much as you want to control the groups and the decision to make the surgery, it's always difficult to prove that this is actually a better technique, because you target different kind of patients with the primary buckle. However, it is still in some instances even more successful than doing a vitrectomy. So you need to know that this is a very important part of our practice still, even if you feel that you're not doing it as much. And so in conclusion of our study, the heads-up sutureless chandelier-assisted sclera buckle offers an excellent solution for surgeon in terms of visualization, ergonomics. It's safe to the patients from suture-related complication and even retinal toxicity. And it's also a superior educational tool for trainees. And this is why adopting it in an academic setting can be a reason for us to teach our fellows and help them adopt sclera buckling more than they would do in other settings. So in conclusion of the study, I think it's time to bring the SB back. I just want to mention at the end of this talk that remaining vitrectomy is a very important part of our treatment too. So this does not take anything away from this. However, thinking about sclera buckle in an old conventional way would always make it lose in any comparison with vitrectomy. But if you go to this thinking of advancing sclera buckling and making it an attractive option for a surgeon in terms of ergonomics, in terms of visualization, in terms of the time that they spend in the surgery, you will always manage to keep it viable, and people will adopt it, and more trainees will adopt it. And with this, I would like to conclude my talk and thank Dr. Hassan for moderating, and thank you all for attending.
Thank you, Dr. AlAkeely, for this really interesting, informative talks. And thanks for bringing back the sclera buckle in the pictures, because we thought at the time that sclera buckle is no more having a place to deal with the retinal detachment surgery. But I would like to thank you for this, and it's important to get back to know the arts of the sclera buckle with different techniques, when you have to do it, when you have to combine it, and you have to make sure, when you are using sclera buckle, we have two types: encircling band as a prophylactic, or that to just support the peripheral retina or the pupillary space. And when you do it as a treatment, primary treatment for the retinal detachment, different techniques were developed with the new era of the micro incision and chandelier lights, the microscopes, even through the 3Ds. So all this could be facilitated to use the sclera buckle. In the past, we are using only the indirect ophthalmoscope, So your stereopsis should work very well. Localizations, use the dynamic and static localizations, and when you miss the localization, whole of the procedure could be failed, while it could be give excellent success if things done on the right way. By this, I would like to open the the discussions, and if having any questions or comments, I would like to invite you all. We will have Dr. Mark with us. I see his bus is muted. If you would like to share us this discussion, Marco.
Hello, hi, Hassan.
Yes, man.
Hi. Now I listen with interest the new techniques. Congratulate Adel for being inventive in this new way of doing buckle. I'm still old-fashioned, I like to do my buckles with the indirect. I think I'm more free in the movements, and it's for me easier than doing it with a microscope. But for sure, the advantage of this technique is that it's easier for the one who are not used to use the indirect to localize it. Localization is the most important in the scleral buckling, and for sure, using the chandelier, it's easier to localize the break. If you don't have a lot of experience with the indirect nowadays. But I mean, whatever it works for me is fine. Both techniques are very good. And just a personal preference. And it's good that Dr. Adel brought us back and remind us about this technique, which nowadays is very much forgotten almost by the younger generation.
Thank you. I'm really still with your way that I'm using the indirect. Just I modified it when I get the presbyopia, so I starting to use the microscope with my suture, placing the radial or encircling bands, and it seems that it's a good to use at certain point. Also, the field getting a little less, but it's really more accurate and easily you can know where you have to go in the sclera, especially with this people, high myopes, thin sclera, because their sclera is very thin to extent that you can get in, without noticing that. So it's using the microscope might help a lot in that. Dr. Adel, would like to make a comment on that?
Thank you, Dr. Marco and Dr. Hassan. I don't want to show you in an old-fashioned way, but the reality is, when I started my fellowship, and I think a lot of us these days are tending to use a lot the 90 diopter lenses with a slit lamp, and maybe sometimes using the contact lenses to look at the peripheral retina. We unfortunately using the indirect ophthalmoscopy is also an art by itself. So being very comfortable doing that is a key in adopting this procedure. However, what I'm suggesting here, that even if you don't master the technique, this is a chance for you to work with a scleral buckle, and it actually, the alternative is offering you even a more, to be honest, a better visualization from the indirect. Let's be honest. And a very important note here, that when you talk about chandelier-assisted buckle, the discussion always is it safe? Are we talking about introducing something into the eye that might cause the risk of endophthalmitis? And this is an argument that I'm sure a lot would mention. And in my opinion, I believe that although this is a risk, but knowing that sometimes we feel ourselves, because we're not comfortable with the buckle, doing a vitrectomy in a patient who would definitely do better with a buckle, actually means worse for the patient. You end up with PVRs that are difficult to manage, detachment that recurs a lot, and maybe if you did a buckle in the first time and it worked, it would have saved you the whole hassle, and the patient the whole hassle. So talking about this and comparing it to the very low risk of developing endophthalmitis or whatever complications that are related to buckle can make a lot of sense in term, and support the buckle a lot.
it was the concept in the past that to do an extraocular procedure rather than to go intraocular. So that's now the modifications to use the chandelier lights. It might help a lot. But in the past, when we don't like to go inside the eye, we are using the buckle. In the past, we are using big tires, which is almost, if you look for it, you can reach to the arcades, which is really it's something that I don't like to use it anymore by the time being. But in the past, our vitrectomy limited, we cannot have wide fields. We don't have that extent to see all of the, the peripheral retina. So using this is most likely to make the retina flat by the end. Is using a lot of cryo. At certain stage, we changed to using the cryo using transscleral diode lasers, which came in certain areas. So it is really evolving and getting more now to use more safe procedure than the getting in the intensive. But sometimes certain eyes you'd like to avoid the vitrectomy as much as you can, because once you get in certain bad vitreous, you might not be able to repair that RDs and getting in the BVR and lost eye. So sometimes buckle is a good procedure for such people. I looked for the study that you mentioned, and comparing, that doing buckle alone, vitrectomy alone, or combined for primary repair, and it's really showed some. But I think so. This is most likely depends on the experience and the expertise. Of the surgeons. Any questions anymore? Because I don't see the hands up so that I can select who would like to ask questions. But opening, I see Dr. Suleiman with us here. He would like to add, or Dr. Abdullah, Dr. Noelati, any one of them, or anyone he would like to ask or add comments.
So thank you.
Go ahead.
Yeah, go ahead, Dr. Noelati. Ladies first.
Thank you. Thank you very much. Thank you, Dr. Suleiman, Dr. Dibi, and thank you very much, Dr. AlAkeely. That was a most wonderful lecture. You went through the steps and you went through the beautiful history, and you carried it further with the new methods of doing things. I fully agree with you that in order to do any procedure right, you have to see. And people shy away when they don't see, when they don't have the control of what they're doing and what they're seeing. And this is why people a long time ago shied away from going into a vitreoretinal specialty, because we used to do the treatments with the very small lenses and small fields of view, and then once the major the pan-fundus view that you have now in vitreoretinal surgery happens, people are happy to do that. But so the message here is that you really cannot be a fully vitreoretinal surgeon if you don't master the art of scleral depression and indirect ophthalmoscopy. That is a must. That is for the fellows and for everybody. And once you have that, then the scleral buckling becomes an art, and it's mathematics and gymnastics for the brain, because you work on the eye, you see where your breaks are, and then you kind of have to do the gymnastics of your brain. What would work best? What is the least amount of things that I can do that can get the job done? And so every surgery is different, and that is very, very we're very happy to do that instead of going into a routine vitrectomy gas, and have and the very, very satisfying thing is for the patient. And what you said about you have to do what is right for the patient, that is absolutely crucial. So the next day when you see the patient and the patient is has a clear vitreous and clear media and is able to see very well, and that the retina has settled down, that is so satisfying to both. So thank you very, very much. I'm a little hesitant, honestly, to if I had to do it again, I would be a little hesitant to do the scleral tunneling thing. But I mean, I guess it works, so it's good to adopt it. And I agree with Hassan that when we reach a presbyopic age, it's much better to do the suturing with the RD1 needle, under the scope, so that you can visualize the scleral depth that you're in. But I just wanted to thank you. You covered everything, and I just wanted to thank you for bringing this back. It's a joy. Thank you very much.
Thank you very much. I'm preparing myself for the presbyopic age.
Dr. Suleiman?
Yeah, just I wanted to echo what Dr. Modalities said. I have nothing to add to the discussion. I want to congratulate Dr. Adel for the job well done in terms of the procedure, taking things, adopting new techniques and the new modalities, and for the excellent lecture. Thank you, Dr. Adel.
Dr. Adel, your talks and last.
I just want to remind everyone that not just for square buckling itself, but always trying new stuff, adopting new techniques, trying out new technologies, tweaking and playing with new devices that you get, and challenging yourself is very important to evolve as a surgeon. This as ophthalmologists, as surgeons. We pride ourselves of being very, very delicate and very, very well skilled. And I think this is something that we should always adopt in our way of thinking of surgery.
Yeah, thank you, Dr. Adel. Just one small things that just in the last 2 weeks, just getting a patient that who had, scleral buckle in form of a circling band, done maybe 3 or 4 years ago. And when I looked for it, it was great. The retina is flat. But when I looked for the height of the buckle, it was really, what I can say, it is making the retina is shocking, too high. So this is one of the things that when we are doing our buckle, we have to look for all the aspects, not to have it too tight. At the time, we'd like to make the retina as flat as much, but actually because this is affecting a lot of the patient's refractions and might lead to complications, erosions. So doing the buckle in the right way is really a great, and it's really a great fun to do and an arts. So I would like all of you, if you can have the times to go back to this and do it in a patient that could be treated only with buckle rather than to go with intraocular procedure.
Thank you, Dr. Hassan.
Thank you very much. Thank you very much for your really great talk. And I would like to thank you all for your attending this grand round, and see you inshallah soon.